So as everyone's logging in, I'd like to welcome you all back to another fantastic Department of Medicine Grand Rounds. You guys are in for a special treat today. As a reminder, if you have questions, if they come up through the discussion or the talk, please feel free to put them in the Q&A session or in the chat, and I will be monitoring that for our guest today. And so I'm happy to introduce Dr. David Himmelstein, who is a distinguished professor of public health at CUNY's Hunter College and a lecturer in medicine at Harvard Medical School, where he was previously a professor of medicine. And he also serves as a staff physician at the Montefiore Medical Center in the Bronx. He got his MD from Columbia and completed his medical residency at Highland Hospital in Oakland, California, and then completed a fellowship in GIM at Harvard. He practiced primary care, internal medicine, and served as the chief of social and community medicine at the public hospital in Cambridge, Massachusetts, prior to his move to CUNY. And on top of all of that, he has authored or co-authored 3 books, and I think the count is now over 150 journal articles, including the widely cited proposals for single-payer healthcare reform, both in the New England Journal of Medicine and in JAMA, along with studies of patient dumping, which actually led to the enactment of EMTALA law, which banned that practice. And as well, on the high administrative cost of the US healthcare system, medical bankruptcy, which he co-authored with Elizabeth Warren, and the moral consequences of uninsurance. And if that wasn't enough, he also co-founded with Dr. Steffi Wohlhandler, Physicians for a National Health Program, whose 22,000 members advocate for nonprofit single-payer national health insurance in this country. So more than qualified to give this talk today, and we're so happy to have you. So I'll hand over the virtual podium to you and let you take it away.
Thanks so much. And I hope this talk will help me get over the trauma of being ranked too low to match at UW 40 years ago. So thanks for having me. And I have no disclosures, but I guess my disclosure is that our healthcare system is in very deep trouble, and that's no secret from anyone. We really stopped making progress on mortality back about 7-8 years ago now, and with the COVID epidemic, we're going to be going further into arrears. And at least part of that is because of the inadequacies of our healthcare system. Part of it is what's been called diseases of despair. But we're doing worse now on controlling blood pressure than we did a decade ago. And clearly that could have mortal consequences for many of our patients. And we're actually relatively unique in the developed world. We're falling off the curve of other wealthy nations that we'd compare ourselves to. So starting in about 1980, our life expectancy really diverged from what our comparator nations in the group of 7, the wealthy nations, have experienced. And at around the same time, by the way, our health expenditures really began to diverge here, graphing health expenditures as a proportion of GDP. And you see we were sort of towards the high end of the pack, or maybe at the high end of the pack back in the 70s. But since about 1980, we've really taken off and are an extraordinary outlier. And during this same period, we've seen widening health inequalities in our nations. This is actually data not of a sample, but of the entire population done by researchers at the Social Security Administration who have information on lifetime earnings and on mortality rates. And they calculated that remaining life expectancy for men who turned 60 back in 1972 varied by about 1.2 years between the bottom half of the income distribution and the top half. And by 2001, it had widened to about 6 years. So widening inequalities. And this more recent study from Raj Chetty and colleagues showing that the life expectancy gap between the richest and poorest 1% of the US population in 2014 had spread to 10 years for women and 15 years for men. So extraordinary levels of health inequality. And those really mirror the growing income and wealth inequalities in our society. In this slide, each line represents 1/5 of the population, the wealthiest fifth at the top and the poorest fifth at the bottom. And you see the divergence between the wealthy and the rest of the population. And if we divided this not in fifths, but in finer gradients, the top 1% and top 0.01% would be diverging even much more sharply. And we've also had a divergence in income according to race. So far from narrowing the inequalities between Black folks and whites, we've seen them widening in the recent period and no progress on this front. And of course, we continue to have extraordinarily high death rates for African Americans and for Native Americans in this country. This data from before the COVID epidemic, and I'll show it a bit later, estimates of what the pandemic has caused. Um, Part of that is broader social problems. We incarcerate extraordinary numbers of people in our society. We're used to thinking of Russia or Iran or China as heavily punitive societies, but we incarcerate far larger share of our population than any other country on the face of the earth. And many of those predominantly people of color, really out of keeping with their share of the population. And in this epidemic, of course, social distancing in prisons has not been feasible. And we see similar kinds of things in other settings where people are confined. Here, the immigration detention facility photo. Uh, or here, which again, many of the poorest in our nation and a growing share are confined to in homeless shelters. So the social conditions clearly play a role in health inequalities. And this estimate from demographers at Princeton showing that they estimate that the pandemic has reduced the life expectancy of the Latinx population by more than 3 years, and for the African American population by more than 2.5 years. Also, of course, reduction in the white population, but health inequalities clearly widening this year. The Black-white disparity in mortality, much of it are things that we can do something about. So 32% of the Black-white disparity is attributable to heart disease, much of that inadequate control of hypertension and hypercholesterolemia, 18% due to cancer, at least some due to inadequate early screening and detection, 12% stroke, again, largely preventable with good medical care. And this data recently from the JAMA showing that, as one would expect, the uninsured have markedly worse control of their hypertension. 22% of uninsured persons have their blood pressure controlled when they're hypertensive, but also African Americans and Hispanics much less likely to have their blood pressure controlled than whites or Asian Americans. We've been making little or no progress towards goals to integrate and diversify medical education. So back in 1976, the AAMC set a goal that African Americans' share of medical school classes should be commensurate with their share of the population. And we made some modest progress until about the mid 90s and have gone downhill mostly since then. And that's not just an injustice to people who would be doctors, it's an injustice to their communities. This randomized controlled trial data from a group in Oakland, California, Stanford and Harvard economists who randomized Black male patients to seeing a white doctor or a Black doctor who followed a predetermined script and recommended various tests or interventions: diabetes screening, blood pressure check, cholesterol test, flu shot. And for each of the recommendations, the Black male was more likely to comply if the physician was African American than if the physician was white. Interestingly, when the patients were asked to rank the doctor by whether they would recommend them to another another person, 99% said yes for both white and Black doctors. The researchers estimate that the difference in the compliance with recommendations for cardiovascular prevention would narrow the cardiovascular mortality gap by about 19% of the total if we had Black doctors for all Black patients who wanted them. We have much higher uninsurance rates for minority groups in this nation than for white non-Hispanic Americans, and that's been true over more than 50 years now. Um, the uninsured rate, which had risen steadily since the passage of Medicare and Medicaid, plummeted with the implementation of the Affordable Care Act in 2014. We can only estimate the increase with the pandemic, but using statistical modeling, Steffi Woolhandler and I estimated in a piece in the Annals of Internal Medicine, the increase you see at the right, that we're now up to 40 million uninsured in this country, despite having the Affordable Care Act in place. That means that last year, so when we only had about 30 million uninsured, about 38 million people in the US died because of lack of insurance. This taken from data in estimates we published in the Annals of Internal Medicine back 3 years ago, that for every uninsured person, about every 760 uninsured persons, about one death occurs each year. That's a summary of all of the trials and studies that have been done of this topic. We would have had many more uninsured if Medicaid had not been sharply expanded. As you see here, we've had a huge growth in the number of people covered by Medicaid, and Medicaid is clearly better than nothing, but Medicaid doesn't get you full access to the care you need. This is a secret shopper study that Karen Rhodes and her colleagues published, calling around to private offices saying, I have a child who was seen in an ED yesterday, and we were told the child needs to be followed up urgently for, in the case of calling an orthopedist, a broken arm, or a psychiatrist for severe depression, and so on. And you see that when they called and said, I have private insurance for the child, 98% of orthopedists would set up an appointment promptly, but only 20% for Medicaid. And the same is true, though maybe not quite as extremely, for other specialties. We've also had, for the privately insured, increasing deductibles and co-payments. So now about half of privately insured persons have a high deductible plan, which means more than $1,350 deductible before you get your care paid for, or $2,700 for a family. And that, we know, is severe financial hardship for many in our nation. So the bottom fifth of the population doesn't have $1,300 in savings that they could put towards a copayment or deductible. And it's um, uh, about a quarter of the total savings of the next income quintile. So copayments and deductibles can have severe financial consequences, but they also can have important medical ones. This data, looking at patients presenting to EDs with MIs and people who were underinsured, which was defined as, I have coverage, but I worry about whether the costs of care will be burdensome despite that coverage, were 21% more likely to delay presentation with an MI than those who weren't worried about the costs. The uninsured, 38% more likely. And this randomized trial with giving free medications for post-MI patients, for minorities, showing recurrent events significantly less likely in the free medicines group than in the co-payments group. A more recent randomized trial actually in Ontario, where not everyone does have free medical medicines coverage. And they randomized seniors to free meds or a control group, and compliance with cardiovascular meds went up, hemoglobin A1Cs went down, blood pressures went down, and LDLs went down in the free meds group. By some measures, almost all of us are underinsured. Very few of us carry private coverage for long-term care. And if we were sick enough, long enough, we would be bankrupted and qualify for Medicaid. But other than that, most of us really are at risk for major financial problems from medical care. And Ilana mentioned that we did some studies with Elizabeth Warren looking at bankruptcy and causes of bankruptcy. This is one result. And here I want to emphasize that of the medically bankrupt, and we found that about 60% of bankruptcies had a major contribution from illness or medical bills. But of the medically bankrupt, 60% had private insurance. So private insurance that was a defective product that failed to protect them from this financial catastrophe. And I learned in working with Elizabeth how common bankruptcy is. American women more frequently graduate from college, more frequently file bankruptcy than graduate from college. So each year, more women file bankruptcy than graduate. In effect, our health policies have been rationing medical care. About a third of Americans are uninsured or inadequately insured. They're often denied care when they need it, and they're sicker and they die younger because of that. Um, and at the same time, we perform large amounts of unnecessary work. So these are RAND Corporation estimates that something like 16% of hysterectomies are clearly unnecessary, and each of the procedures we could name are done in excess, largely on patients who are well insured. So we've adopted the term that our health policy has really focused on rationing a surplus. We have thousands of empty hospital beds at most times in this nation, millions of unnecessary operations, and an excess of high-tech facilities. We know, for instance, that regionalizing cardiac surgery improves outcomes, and yet it's a lucrative procedure. So we have an excess of hospitals that want to do it. When I showed this slide to one of my colleagues years ago at Harvard, he said, "You're misusing the term rationing." The dictionary defines rationing as an egalitarian distribution of a scarce resource. And of course, our medical resources in most circumstances in this country are not scarce. So we ration that surplus, which I think of as a little bit of an oxymoronic phrase, kind of like political leadership. Takes a lot of effort to keep sick patients away from idle physicians. I've graphed in yellow here the number of physicians in the US and in blue the number of managers. And you see that the fastest growing element of our healthcare system is managerial personnel, growing at many-fold faster than doctors or nurses. There are, of course, people who are doing very well in our healthcare system. So Martine Rothblatt took home $45 million last year. Larry Merlo, for running Aetna, took home $36 million. But those dollars come out of our patients' pockets. And the overhead of insurance firms is one place where they leak out of the healthcare system. So back in the second quarter of 2019, United Healthcare had an overhead of 16.9%. So only 83 cents of every dollar ended up paying for care. The second quarter of this year, that was down to 70%. So 70 cents of every dollar actually went for care. And they were not unique. Aetna was making out like bandits, and Cigna as well. Humana, not quite as good, and Anthem, not quite as good, but certainly extraordinarily healthy profits. Years ago, we looked at who were the largest owners of tobacco stocks. And at that time, some of what were then some of the biggest health insurers in the country um, were the largest owner of tobacco stocks. So we labeled that the combined taxidermist and veterinarian approach. Either way, you would get your dog back. But Milton Friedman told us years ago what to expect when we allowed the profit motive to dominate our healthcare system. He said, few trends could so thoroughly undermine the very foundations of our free society as the acceptance by corporate officials of a social responsibility other than to make as much money for their shareholders as possible. And that's what the insurance firms do. And that's what dialysis firms do, for instance. So here's the results of a meta-analysis of all of the studies that were published at the time in 2002, comparing death rates at for-profit versus non-for-profit dialysis facilities with adequate adjustment for patient severity. And they found a 9% higher death rate at for-profit dialysis clinics. I should say that there is an update of this meta-analysis forthcoming with much the same finding today. A meta-analysis of for-profit hospitals' death rates, not so extreme, but higher death rates found at that time at for-profits. And they were not more efficient at anything but extracting money. So for-profit hospitals, again, a meta-analysis by the McMaster Group, cost 19% more on average caring for comparable patients than not-for-profit hospitals, and yet use that 19% excess to achieve higher death rates. Hospice now increasingly in for-profit hands. 70% of hospice is owned by for-profit firms in 2018. And to complete the brief tour, private equity and venture capital firms now buying up physician practices at an enormous rate. 20,000 physician practices bought by a venture capital firm in Los Angeles just in the past 2 months. Health industry profits remain extraordinarily healthy. Pharmaceutical firms, by far the largest, but other elements of our healthcare system, extremely profitable for firms. And we might say, well, drug companies should be allowed to make a profit, but should they be allowed to make a profit threefold higher than the average of the Fortune 500 year after year after year? That, in fact, has been their record. The contention that they use that money, those profits for good, is by no means backed by data. So over the 10-year period between 2006 and 2015, the 18 firms in the S&P 500 spent more than $500 billion on dividends and stock buybacks, and less than that for R&D. This advice from Goldman Sachs, who asked, in biotech research, is curing patients a sustainable business model? And their quote from the report was, the success of Gilead's hepatitis C franchise has gradually exhausted the available pool of treatable patients. In the case of infectious diseases such as hepatitis C, curing existing patients also decreases the number of carriers able to transmit the virus to new patients. So cure is bad for the market. And that's the ethic that we've introduced into our healthcare system. And it's a healthcare system that is funded 2/3 of it by taxes. So we're used to thinking of Medicare and Medicaid as tax funded, but also the VA, public health, and so on. But if you add to that government workers' benefits, so we pay for police and fire department benefits and teachers, and tax subsidies for private insurance, fully 2/3 of total health spending in the US comes from government coffers. And if we graph US spending per capita as compared to other developed and wealthy nations, our public spending, which I show in yellow on this slide, is only surpassed by Switzerland in total spending. So we spend more in public dollars than any nation but Switzerland spends on its entire healthcare system. In effect, we pay for national health insurance, but we don't get it. Um, our life expectancy, as I showed at the outset, trails most other developed nations. Um, uh, and our infant mortality rate is distressingly high. Um, our maternal mortality rate more than double that of most other developed nations. And just to make the point that even white non-Hispanic women in the US have maternal mortality that's substantially higher than nations that we would compare ourselves to. And of course, African American women's virtually off the chart here. Um, we don't spend so much because we are avid consumers of medical care. So here are how many visits per capita people in various countries get. And you see that Americans don't get a lot of doctor visits. We don't get a lot of inpatient care compared to people in other nations. This is OECD data. Um, our high costs can't be blamed on smoking. uh, we smoke less than people in most other nations that we'd compare ourselves to. Um, and we can't attribute our high costs to a large immigrant population. Immigrants make up a smaller share of the US population than, again, many other developed nations. What we get an extraordinary amount of is healthcare bureaucracy. So here's the per capita, per person in the United States expenditure for insurance overhead compared to other nations. So we're spending about $600 per person more than people in most other nations just on insurance companies. And insurance companies at this point are deriving most of their money from Medicare and Medicaid. So we've said with the private insurance market shrinking, we're going to step in and privatize an increasing share of Medicare and Medicaid and flow that money through private insurers, and they take their cut. And their cut is very large. Here, the Medicare Advantage program, where about 13.6% of the total revenues paid to the Medicare Advantage plans ends up staying with those plans as profit or overhead. The traditional Medicare program runs for about 2% overhead. And these are somewhat older figures, but they hold true today. We've recently reviewed this literature. Yet despite Medicare's lower overhead and broader provider networks, Medicare Advantage plans continue to outcompete traditional Medicare. And they're doing it by cherry picking, upcoding, and lobbying for overpayment. So here's the enrollment in Medicare Advantage, or Medicare HMO as it's been called, which is skyrocketed despite that high overhead. And the key thing that Medicare Advantage plans have understood is that a few people account for most medical care. So each bar here represents 10% of the population. And as you go to the right, you're going to heavier utilizers of care. And you see that the 20% of the population that uses the most medical care accounts for about 80% of total medical spending. So as a Medicare Advantage plan, if you avoid them, you collect the premium from Medicare, and yet you pay out very little in the way of actual expenses. So this is not only true for spending of the population at large, but for instance, 18% of Medicare patients cost Medicare nothing in the course of a year. So in Boston, if you sign up those patients, you get about $14,000 a year as a Medicare Advantage plan, and you pay out nothing for that patient. So there's cherry picking and what we call lemon dropping, getting rid of the expensive patients, upcoding and overdiagnosing in order to increase your risk adjusted payments. Well, in the year before patients sign up for Medicare Advantage, those who remained in public Medicare cost about $2,000 more than those who switched to Medicare Advantage. They were in Medicare, traditional Medicare. Um, they cost $2,000 more, and subsequently they switched to Medicare Advantage. So it was the low cost patients who were switching, and this is adjusted for the risk scores that determine the payment to Medicare Advantage. So powerful evidence of what we call cherry picking. How would you lemon drop? Would you get unprofitable patients to disenroll? Well, one way is, for instance, to require high copays and co-insurance for chemotherapy. So cancer patients will go elsewhere. Now, more than 80% of all um, Medicare Advantage patients have copays of at least 20% of it, co-insurance of at least 20%, or copays of at least $75 for chemotherapy. And that's one way you can chase them out of your plan. Um, we know that patients who acquire new disabilities are likely to switch out of Medicare Advantage back into traditional Medicare, and those who switch into Medicare Advantage much less likely to be the ones who have acquired new disabilities. So this is the lemon dropping phenomena. And here looking at illness as measured by whether you were in a nursing home. Those who had a short-term nursing home stay about 3 times as likely to subsequently drop out of the Medicare Advantage plan, and those with a long nursing home stay nearly 6 times as likely. So um, very strong evidence that they get rid of patients. What about the upcoding that increases how much you get paid for a patient? Well, here's a simple example. If a patient who has diabetes and uncomplicated diabetes, the Medicare Advantage plan back in 2017 would have collected $4,990. But if they label the patient with diabetes with chronic kidney disease, stage 4, morbid obesity, major depression, and angina, they get an extra $13,000. I submit to you that to a large extent, these are the same patient, but there is more careful coding on the second case. That's legal. What's not legal is billing for diagnoses that are never appear in a medical chart. And when CMS has audited the Medicare Advantage plans, they find that a common occurrence to the tune of about $9 or $10 billion each year in false billings. But they have failed to go after these plans for those false billings. Um, Not only that, but another way you can up your payment is by cheating on the quality measures that determine your quality bonuses. And the group at Brown cleverly figured out a way to actually look uh, at the measure that was reported to HEDIS, which that is the basis for the quality scores. And what they found is 95% of the Medicare Advantage plans were cheating on their HEDIS quality scores, and plans that didn't cheat were downgraded and therefore denied bonuses. So if you don't cheat, you lose in this market. Another recently published example from that Brown group, they looked at 30-day readmission rates that were reported to Medicare or that in fact occurred, and the 30-day readmission rates were underreported to Medicare by the Medicare Advantage plan. So in effect, um, Medicare Advantage plans have become good at cheating, and they have not needed to become good at anything else. Um, I'll just briefly say that ACOs, a different flavor of a similar incentive, um, have thus far saved almost nothing for the federal government. So the estimate from the MedPAC staff and CMS is that thus far in 6 years, they have saved $0.67 billion, which is 0.115% of total spending. And meanwhile, the estimate of their administrative cost increase attributable to ACOs is $8.52 billion. ACOs were part of the Affordable Care Act as it was passed, and here I've diagrammed the simple diagram of how the Affordable Care Act structure works, and the Republican alternative on the right. And I just want to emphasize that what I will spend most of the rest of the time talking about is a simple alternative that I think would work better. Here's the software that actually was used to get Medicare underway. This is the first person who signed up for Medicare. Um, the Social Security Administration sent postcards to everyone in the country who was registered with Social Security and would be eligible for Medicare. And they sent out farm extension agents and Forest Service agents to rural areas where there was no postal delivery. And all you had to do was check a box to decide whether you wanted Medicare Part B or not, sign your name, and you were signed up. And they enrolled nearly 19 million seniors without the benefit of computer technology within 11 months after the day that the legislation was signed. Medicare, which was passed roughly the same time that Canada implemented its national health insurance, has similarities, at least at the outset for Medicare, before they allowed private Medicare Advantage plans into the Canadian plan. So I'm going to use that as an example of some of the benefits of single payer. So Canada's program is a simple one. The federal government offers provinces financing if they meet 4 conditions. They have to cover everybody, which in effect means that 99% of people have to have picked up their insurance card. Benefits have to be portable from province to province. So if you're from British Columbia and get sick in Saskatchewan, you have to be covered by British Columbia. Coverage for all medically necessary services, which the feds have not defined. Back in the 60s when the program was passed, that really meant doctor services and hospital services, and they have failed to modernize it to cover prescription drugs and long-term care. And there's now quite a battle in Canada, particularly around the prescription drug expansion, much needed. And they mandated public administration through a nonprofit program because when they tried subcontracting it to a private insurer in Saskatchewan, it cost 4 times as much as it would cost to do it in the public sector, analogous to our experience with Medicare. Within 1 year in the province of Quebec, and there were population-based surveys that were done, the proportion of patients with a serious illness who actually got in to see a doctor increased dramatically. It didn't change much for wealthy people, but it changed among the poor, and $3,000 back then is probably the equivalent of about $25,000 now. But these are people who had things like chest pain or urinating blood or coughing up blood. Not all of them went to see the doctor. It didn't solve all the problems, but this one change made a huge difference. The infant mortality rate in Canada, which was higher than ours until they passed their national health insurance program, fell below ours and has remained there since then. Infant deaths in the poorest 20% of the Canadian population are equivalent to our average, and they still have a gradient by socioeconomic status, but as shown in this slide, far lower than ours. And this actually shows that in Canada, over the last 3 decades, all income groups have gained life expectancy And as you see in the US, the poorest have actually seen their life expectancy fall, and the richest increasing dramatically. So health inequalities remain, but have been substantially attenuated in Canada, certainly as compared to the US. Cystic fibrosis patients live substantially longer in Canada, even as compared to privately insured cystic fibrosis patients in the US. So here's a group that requires extensive high-tech care, and yet does better in Canada than in the US. Canadian physicians do fine. These are Canadian dollars, so you need to discount them by about 30%. But incomes of doctors in Canada are reasonable, and doctors don't starve there. And few of them choose to emigrate to the US. In fact, in most years in recent times, more Canadian doctors have been moving back to Canada from the US than the other way around. Um, Health costs, which were quite comparable as a proportion of GDP in Canada until they passed their national health insurance program, quickly flattened out compared to ours and have remained far below ours. And much of the difference is bureaucracy. So here's data that we actually just published this year in the Annals of Internal Medicine. As I said earlier, we're spending about $800 per person more for insurance overhead than they spend in Canada. But it's not just insurance overhead. So about $800 in hospital billing and administration costs per person, higher in the US than in Canada. And just to make that concrete, um, Duke Hospital, 957 bed hospital, employs 1,600 billing clerks. And the billing costs are about $99,000 per physician. In Canada, hospitals are paid like a fire department in this country. They get one check a month to cover their entire operation. Um, and they don't bill for each Band-Aid and aspirin tablet or patient by patient. Years ago, I was visiting a friend hospitalized at what was then called Toronto General Hospital, 900 bed tertiary care referral center. And he was an American and asked us to look into his bill. And the billing office at Toronto General was 3 people whose task was to send bills to Americans who happened to wander across the border. And when we got back to Boston, we uh, went by the billing department in Mass General that at that time had 432 full-time equivalent personnel. It's grown very greatly since then. Um, it's not that Mass General or Duke are inefficient. It's what you have to do to remain afloat as a hospital in the US and not required of Canadian hospitals. And um, here's the American Association of Professional Coders, 190,000 members and growing. This we support out of our healthcare system. And of course, it's also physicians' practices that bear a huge burden of the costs. About $400 per person in the country for physicians' billing related expenses. And of course, here's the kind of ads that are directed at physicians. I will squeeze every dime out of every claim. Um, and it's not just the billers and coders, but our time. So this study looking at the length of notes on Epic, so all using the same EHR in US versus other countries. And you see that US notes are far longer in ambulatory care than in other countries using the same EHR because of the documentation burden that we face. Overall, we're spending about $2,800 per person on billing and bureaucracy that we could save if we went to an efficient single payer system. And that's enough to cover all of the uninsured and to upgrade coverage for people with copayments and deductibles, to improve long-term care, and to do what needs to be done to upgrade public health, whose share of health spending has been falling in the US. You know, Charles Dickens, in a story called The Seven Poor Travelers, I think wrote a very apt description of what we observe in medical care. He said, I found too that about a 30th of the annual revenue. It was revenue that was supposed to support a hostel for poor travelers. 30th of the part of the annual revenue is now expended on the purposes commemorated in the inscription above the door. The rest being handsomely laid out in chancery, law expenses, collectorship, receivership, poundage, and other appendages of management, highly complementary to the importance of the six poor travelers. And the phrase is actually six poor travelers, even though the story is titled Seven Poor Travelers. So I think an apt description of what we now face in our healthcare system. So what I'm advocating is a simple national health insurance system that would cover everyone for all needed care without copays, with a single public payer and simplified reimbursement, particularly with global or lump sum budget for hospitals that they would have to spend on their patients, could not keep any of for surplus. And if they want new buildings or to make new investments in equipment, that ought to be regionally planned. So they ought to apply for a grant from the single payer to do that. No investor ownership, because we have substantial evidence that it worsens quality. We need to improve health planning so we don't have the duplication of facilities that both increases costs and lowers quality. And we need public accountability for quality and cost, but not through the kind of bureaucracy that we've erected. Now, there have been, by a meta-analysis published in PLOS Medicine this January, 24 studies of estimating single payer costs, including those of the General Accountability Office and Congressional Budget Office some years back. All of them but two have concluded that single payer could cover everybody and upgrade coverage and actually reduce costs. So this is a study funded by the Koch brothers that concluded that single payer would reduce medical spending by about $2 trillion in between 2022 and 2031. All of those studies actually conclude that doctors' total payment gets more, but that less of it is spent on bureaucracy. But doctors would have to do more work because there would be more patients to care for. So we would shift some of the time we now spend on billing and bureaucracy to work spent taking care of our patients. I just want to very briefly say that it's important to beware of single payer sound-alikes like Medicare Extra for All or Medicare Advantage for All or Medicare Public Option, which unfortunately has been what I hope will be President Biden's proposed reform. These would not, because they retain private insurers in the mix, uh, achieve the administrative savings of a single payer program. So in each of these, you get less care and therefore cost pressures continue to mount. The best example of a Medicare public option that we have is the Medicare Advantage program, which essentially uses the traditional Medicare public option as a high risk pool to dump the unprofitable patients into. Um, well, um, this study from published in the Lancet this year that estimated that a single payer would cost $631 billion less than a universal multi-payer system. Let me just end by saying that I'm not completely absent from reality. These are the two tallest buildings in Boston as seen from near my home in Cambridge for many years. And those are both insurance buildings. And we're talking about putting them out of the healthcare system, and that's a heavy lift politically. But growing numbers of Americans supported about 60% in polls in 2017, and that's continued to be true through this election season. About 60% of Americans say that single payer is what they want, including, by the way, something like half of Republicans. Um, Most doctors, according to recent surveys, now say they support single payer national health insurance, though most of us think most of our colleagues oppose it. Well, let me just say that I hope that we someday get to the point that they got to in Britain. This is the leaflet that was sent out when the National Health Service was started in 1948. Your new National Health Service begins on 5th July. It will provide you with all medical, dental, and nursing care. Everyone, rich or poor, man, woman, or child, can use it or any part of it. There are no charges except for a few special items. There are no insurance qualifications, but it is not a charity. You are all paying for it mainly as taxpayers, and it, and it will relieve your money woes in times of illness. So thanks for your attention, and I hope I haven't said anything that will distress you.
Thank you so much for that incredible, comprehensive, and incredibly timely talk, especially right now. We do have some questions, and I think the first question I'll ask you is from our audience: is incremental improvements in such a broken system even possible, or will any intervention cause more unintended consequences, and thus a paradigm shift like you're proposing as actually what's necessary for those who desire improvement?
Yeah. Well, when my patients complain that they have a grave illness and want to take Tylenol for it, I don't tell them not to take Tylenol for it, but what I tell them is that's not going to fix it. So for our healthcare system, I'm all in favor of anything that's going to help a few patients. And the Affordable Care Act did help people. It also had side effects, and it didn't cure the system. We need a cure.
Yeah. And I think in the same vein, or along that lines, another audience member asks, is there a way to make single payer more palatable politically, especially in this climate, such as providing basic healthcare to everyone and transitioning private insurance companies to solely providing supplemental insurance, or any other ideas that you may have?
Yeah. I've wrestled with this one for 30 years now. The only thing I can think of is for instance to say that we're going to cover all inpatient care under a single payer program and pay hospitals in a rational way. But then that will create side effects like shifting care from the outpatient side to the inpatient side, because private insurers would be paying for the outpatient care but not the inpatient care. So I think there's a big chasm we need to cross, and small steps are going to be problematic in doing that. So I wish there were an easy way to do this. I think that any reform that's really going to make a very substantial change in the system is going to caused tremendous opposition from insurance firms and drug firms, because frankly, one of the things that a rational program does is bargain with drug firms. So we would drive their prices down, and there's I don't think a way of getting around that.
Yeah, and sort of in that vein is another question of what are estimated impacts on job losses in single payer public system, particularly since you noted the sheer number of people employed purely to be coders.
Yeah. Well, we've actually published some personnel estimates. We estimate that there are about 1.25 million people doing useless bureaucratic activity in the healthcare system. And we would need to find useful jobs for them. So the single payer bills in Congress and most of the ones in states actually include funding for job transition programs for displaced insurance and administrative workers. Now, my personal favorite is Jack Rowe, who used to be the chief of geriatrics at Harvard and segued to be the CEO of Aetna. And Jack made $225,000 per day during his stint at Aetna. So we wouldn't be able to find comparable employment for Jack, but most of the insurance and administrative workers are actually relatively low wage workers, and we need to find useful things for them to do. So that's part of the transition. We actually didn't say that farriers would remain employed just because we got cars to replace horses. We might have been better off if we'd kept with the horses.
That's possible. Another question from the audience is what is your vision of academic medical centers under a single payer system?
Well, having worked most of my career at academic medical centers, I think they need to be globally budgeted, and that budget needs to take into account not just their patient care activities, but their other academic activities. So, one of the advantages of a global budget is that you don't have to tie funds to an individual patient, and that they can recognize not only the kinds of activities that we do in academic medical centers, but also, for instance, community public health activities. If you want to have a smoking intervention in the community, or a school health intervention that's carried out from an institutional setting, funding can be rationally allocated for that. So I think global budgeting is the right way to do it, and we're going to need to fight for adequate funding for academic medicine in any system.
Yeah. And I think there's another great question of folks really want to know how we can actually impart change. And one question arose, the Canadian single payer system started with one province. Could we start the transition to single payer by starting with one state?
So yeah, I mean, it was Saskatchewan that started it. A guy named Tommy Douglas, whose grandson is named Kiefer Sutherland, for those of the younger generation who know him, and was voted the most popular Canadian of all time. So yeah, I think a single nidus of infection can spread in the US as well as in Canada. It's a bit harder to do at this point in the US than it was when things were more isolated in Canada at that time, but I think it is feasible. And I would say that you have in Washington state a very strong single payer movement, a strong chapter of Physicians for National Health Program, and that collaborates closely with others in the community. So we'd love to see Washington lead us.
Like that's a call to action for those in the audience. So take note, everybody. And then we have a time for a few more questions, but one from the audience is, could you talk about the role of population health initiatives under a single payer plan?
Well, I think there are a couple of things about that. One is my own view is that population needs to be defined not by the clinical population, but by the residential or work population. So where people live is the right unit for intervention when we talk about population. And what's going on in the ACO world at this point is that whoever you happen to choose as your population or attract as your population is what you declare as your population. So I think we need a true population base for that, and that means collaboration among health institutions, and probably, in my view, leadership from the public health department rather than from the clinical medicine setting. So I'm a big proponent that we need to strengthen public health. We've had falling public health spending in this country since the year 2002. We're down to, or at least before the pandemic, we were down to 2.5% of total health spending going for public health activities. Canada spends 6% of its expenditures on public health activities. And one of the reasons, for instance, British Columbia had a much more successful response to the pandemic than we did in this country was that they had public health leadership that was able to coordinate the population-based activities that were needed. So I think we need population-based interventions, and that's going to involve those of us in clinical medicine, but under the aegis of public health, not under the aegis of clinical work.
Yeah, absolutely. Well, it looks like we are just at time. And I want to again thank you so much for virtually spending an hour with us here on the West Coast for a really timely and fantastic talk. So thank you. Thank you so much for taking the time. It was really wonderful and much
Thanks so much for having me. And special thanks to Chris Wong, who has worked tirelessly in Society for General Internal Medicine. I've learned a lot from, and arranged for me to give this talk. So thanks to you and to him.
Absolutely. And just a reminder for folks, next week we'll be here same time, same place. We'll be having Dr. Alec Mormon talk about the ischemia trial. So a different topic, but also should be wonderful as well. So thank you all for joining us, and have a fantastic Friday afternoon.